Hey FRT community. So I got a couple of things I want to touch on. First of all, you see there's some information on the board behind me. This is a scenario that I received last night via Instagram. I had a student send me a message, said, hey, this is what was going on. Can you help walk me through it? I want to make sure I was thinking correctly about this. So I want to talk about this scenario briefly. And then I also want to address a comment that I had from a student, I believe his name was Farrar. And Farrar wanted to know if there was any recommended readings or fun reads over respiratory therapy during the break that he could read and kind of stay up to date on. So here's my stance on this. First of all, if you're looking for a good book or something that's an easy respiratory therapy read, I like the Mechanical Ventilator book. I think that's actually the name of it, if I'm not mistaken. Let me see here real quick. Hold on just a second. Okay, so it's called Just the Ventilator Book, and it's written by William Owens, MD. So this doctor wrote this. It's called The Ventilator Book. It's a green book, and it's not too thick, and it reads pretty good. It's actually a nice resource to have. I know several of the ICUs around here actually use it as their orientation guide. Now, that's if you insist on reading a respiratory therapy book. Most of you probably don't. Now, I also don't suggest you studying your butts off over the break. It defeats the purpose of the break. The winter break, this 3 to 4 weeks you have off right now, is meant for you to get away from the intense learning environment and to enjoy life in a different way. Not having to study, not having to prepare for exams, not having to prepare assignments, not having to do projects, not having to collaborate. Have a break from your classmates. Reconnect with your friends that you haven't seen in a while. Spend time with your families, with your babies, with your spouses, with your boyfriends, girlfriends. All those things I've already said in a previous video. Spend time with them. And then come back rejuvenated in 3 to 4 weeks. Don't spend this entire break studying 1 to 3 to 4 hours a day. Not a good idea. You're just going to overload yourself. You're going to come back from break and go, sheesh, I need a break from break. And then you're going to be in the thick of it, either 5th semester, if you're in a bachelor's degree program, somewhere in the middle there. And if you're a first semester student in an associate's degree program, you're coming back starting in the spring, in January, second week of January, and you don't get another break like this for a whole year. It's not until winter break next year that you're going to have multiple weeks off to just get away. So just get away and do something fun. Okay? Now, if you have the desire to stay sharp, if you're looking at this going, you know what, man, I'm weak and I'm afraid that I'm going to come back in 3 weeks, 4 weeks, whatever it may be, and I'm going to be further behind than what I already feel I am, and you have this desire to stay sharp during the break, then here's my recommended tips for staying sharp during the winter break, okay? Right now, pause this video in just a second, pause this video, and make a list of 5, 10, 20 very specific topics that you are afraid of forgetting. Things that were challenging for you to grasp. Maybe you took a final and you noticed that, oh man, I'm still weak in this area. And write down, like I said, this is your study, this is your tip, so you take it how you want to. However many you want to, 5, 10, 27, 12, doesn't matter. Just make a list right now. Pause this video, go get a sheet of paper, make that list right now. When you're back, I'm going to tell you what to do with that list. Okay, so you have your list made. And now what do I do with this list, Joe? Now, you get you some index cards. And for every point on your list, you create an index card. And this index card should be very quick hitting index cards. 1 word on the front, 1 or 2 points on the back. That's it. Or put them all on the front. It don't matter how you do it, right? You do you. But very, very brief information. This should not be, I see index cards. I like index cards, but I like effective use of index cards. I see some students have index cards. It's like, damn, did you put the whole lecture on one index card? And that's not effective because you just end up reading PowerPoints that you just transposed over to an index card. And I don't know how much you actually retain from that. What I'm talking about here, very brief, very, very laser focused points. Now, once you get your index cards made, okay, let me give you an example of what an index card should look like. If you struggle with PFTs and you're like, man, I cannot remember the FEV 1%, then you should have an index card that says FEV 1%. And when you flip it over, it should say the amount of volume exhaled in the first 1 second of a forced vital capacity. And then below that, it should say if less than 70%, it equals obstructive lung disease. If greater than 70%, then there is no obstructive lung disease. It could be normal or maybe a restrictive lung disease. You need more information. But just from the FEV 1%, less than 70% would be obstructive, greater than 70% not obstructive. Okay, that's an example of a card I'm talking about. If you're talking about modes of mechanical ventilation, I wouldn't do one that says modes of mechanical ventilation. I would do one that says SIMV. I would do one that says AC. I would do one that says volume ventilation. When you flip it over, volume is set, pressure varies. Things like that. Okay, now, once you get your cards made, you put them in a stack. You go put them by somewhere that you go to every single day. You go to the sink and brush your teeth, hopefully. You go to the restroom. You probably get in your car a lot of times. I don't recommend them going in the car because don't drive and read. That's not usually going to be real focused. You're not going to be able to get into it. But the first two areas are really good. So while you're brushing your teeth in the morning, grab one index card and review it for less than 5 minutes. That's it. 5 minutes max. Read it. FEV 1%. Flip it over. Less than 70% obstructive. Greater than 70% not obstructive. And review that one card for less than 5 minutes. 5 minutes out of your day. Put that card at the bottom of the stack. And the next day, do the next card. Now, do not do 2, 3, or 4 cards a day. You want to review one concept once a day, less than 5 minutes, and then marinate on that concept throughout your day. Don't consume yourself thinking about it all day, looking it up on the internet and stuff. Just from what that card said, throughout the day, later that night you're cooking, you're making dinner, think to yourself, FEV 1%, less than 70% obstructive, greater than 70% not obstructive. The next day, when you brush your teeth, do the next card, SIMV. Patient can breathe in between true spontaneous breaths, in between scheduled or set mechanical breaths. Okay? That's how I recommend you staying sharp during the break without overloading yourself and without trying to spend a whole lot of time studying so that you're just as tired at the end of the break as you were at the beginning of the break. That's not going to be good for you. Okay? Quick hitting index cards once a day, less than 5 minutes, one card a day. Broad, easy concepts. Okay? Try it. Hey, give me some feedback. If anybody does this technique, I want to know. I want to know how it works out for you. And I want to know if you liked it and if you actually feel like it may have helped. Okay? Now, here's the scenario that I got a message from last night on Instagram. Student said, hey, Joe, help me with this scenario because I'm lost. I said, no worries. Now, this is a student that's also working as a student respiratory therapist in a facility in our local area. And hopefully a lot of you may be working as student respiratory therapists right now, and you're going to see scenarios like this. And I think it's amazing that she didn't step away from it and say, well, I can't really partake in ICU care because as a student respiratory therapist, you're usually confined to floor therapy. Instead, she infused herself into it, and she made a learning moment out of this in watching and observing. Okay, now, mindset was I felt dumb because I couldn't keep up because there was so much happening. But don't feel dumb, you're learning. And so you're soaking all this in. The purpose of this is to soak it in, make it make sense in your own time as you're learning. And then in a few years from now, when that's you at the bedside, you're better equipped for it because you've already seen this scenario. So here's the details that were given to me. Patient came up from the ER, or maybe they were still in the ER. I don't know if they came up or they're still in the ER, but it doesn't matter. They were intubated, they were put on a ventilator, they were put in volume-controlled AC. Now, this is important. This is super important. They went into AC. Student goes on to tell me that the patient was pulling tidal volumes of 1,000 mLs. Now, that's a key part of this. Okay? And we'll go back to that in just a second. Tidal volumes of 1,000, patient pulling tidal volumes of 1,000. PIPs were in the 50s. The patient was hypotensive and desatting. No crap. This is what's happening? No crap, they're hypotensive, right? So lots of mean airway pressure happening here that can impede venous return. And in an already upset, struggling heart, patient ends up having a massive MI ultimately. And all we're doing is putting more strain on them with these things right here, right? So here's how we break this down. My questions in response to this initial information with this data was, what's the patient's set tidal volume? Question mark. And then I followed it up with 500? Question mark. See, I knew the patient was on a tidal volume of 500 before the student ever even told me this because of this reason right here. We're in AC, which means we have a set tidal volume, and if the patient breathes above that set rate, then they can trigger another mechanical breath. But in that next mechanical breath, they will get another tidal volume that is the set tidal volume. So the only way in AC a patient can pull 1,000 tidal volumes, it's not that they're pulling 1,000, it's that the vent is delivering 1,000. And you have to remember, you're measuring exhale tidal volume. That's key. So, the patient's not set on 1,000. That's just ludicrous, right? Nobody's setting 1,000 ml tidal volumes anymore, and as well you shouldn't. Okay? So, how are we getting 1,000 mLs exhale tidal volume in AC when what is being delivered is going to be set? Well, the answer to that is the patient must be breath stacking. Now, this makes sense. Why did I think 500? Because I thought to myself, well, if the patient is breath stacking, then 2 500s will equate to 1,000, and that must be what's happening. And that is ultimately what was happening, because the student came back and said, yes, they were on a tidal volume of 500, and the set rate was 16, and the total rate was 2930. Now, that also makes sense, right? Almost every machine breath that was given to 500, there was another breath being triggered, which was equating to these exhale tidal volumes of 1,000 mLs. Now, right now, we can eliminate this word pulling, because the patient wasn't pulling 1,000 ml tidal volumes. The patient was getting 1,000 ml tidal volumes. Now, how are they getting 1,000 ml tidal volumes when they weren't set on 1,000? 500 times 2. And this is exactly what happens when you breath stack in VCAC. Remember, the vent is as smart as it is also stupid. It goes, oh, you want another breath? I don't even know that I just gave you one. All I know is that you want another one. Yeah, I just gave you 500, and your diaphragm continues to drop, which immediately triggers another breath. Don't care that I just gave you a breath and you haven't exhaled. You're asking for another one? Here's another 500. And then exhalation happens, right? Because the patient's diaphragm is not going down still at the end of that second breath. If it was, we'd call it triple stacking. With triple breath stacking, and we would get 1,500 mLs. That would be crazy, right? So typically, a patient's diaphragm continues to drop at the end of an inadequate set tidal volume, and they trigger another breath immediately. We call that breath stacking. It's very common in AC. You got to be able to pick up on it. I'm going to show you what the waveform is going to look like here in just a second. I'm actually going to erase this right here and show you right now. So you got a pressure waveform and you have a volume waveform. So the volume 500 goes in, and immediately the volume waveform does like this and delivers another one. And then you get this exhalation, and it goes way down below baseline. This was the first 500. Below baseline is the second 500. Okay? See, this is what I'm talking about. The vent doesn't understand that when you trigger this next breath immediately, that it goes, oh, just keep this breath going. It doesn't. It cut off. The vent actually cycles into expiration. But because of the immediate triggering, you get another breath delivered, and the vent always resets at 0 and goes, okay, another 500. Boom. Okay? So that's how the two breaths are happening. Now, when you look at your pressure waveform, it looks like this. First breath goes in. Second breath goes in. And then it comes back down and to baseline for PEEP. This was the first 500. This is the second 500. And this is how we had 50 centimeters of water pressure on our peak inspiratory pressure. If you were to look at your pressure your pressure volume loop, it would have looked something like this. Okay? It would look, this is what over distension looks like if somebody was taking 1,000 mLs, peaking out at 50. Okay? Now, what this one was doing in AC was probably looked more like this. So you had your first breath go in, and then immediately you trigger another breath, and because the lungs are already full and now they're not as compliant, you get the second breath looks probably something like this. Pressure goes way up to 50, and this is what the second breath would look like. So you get these alternating pressure volume loops because the vent's going to redraw the pressure volume loop for every breath that's delivered. And you got to remember, you're not delivering, the vent in its mind is delivering 500 mLs each breath. They just happen to be happening right behind each other and one on top of the other. So you get these rise in pressures on your graphics that you can identify. Okay? Now, the biggest thing is when you see this, what are you supposed to do for it? Okay? And why is the patient breath stacking? Patients who breath stack have an increased ventilatory demand, meaning that when you put them on 500, their diaphragm is still dropping at the end of that breath, and that's what immediately triggers a second breath, and it leads to breath stacking. Now, why is the diaphragm dropping still? Because the patient wasn't satisfied with the 500. You got to remember, you got a vent that is very much in control here. It's controlling the way these breaths look. But if that doesn't match what the patient wants, then you're going to get this asynchrony. You're going to have breath stacking, flow hunger, things like that are going to affect your peak airway pressures and all your other parameters, right? So because the diaphragm is still dropping, you have to figure out how much volume does this patient really want. Now, we all know that we go 6 to 8 mLs per kilo, ideal body weight, get their ideal body weight, 6 to 8 mLs per kilo, figure it out, put them on it. Well, depends on the size of the guy. If you're on a tidal volume of 500 and the guy is, 70 kilograms, well, 6 to 8, right, mLs per kilo, this would be 420, and you can go as high as 560. So to fix this, you just have to find out how much volume does the patient want. Now, here's what actually happened. They said, oh, you want 1,000? We'll just put you on a tidal volume of 900. So they increased it from 500 to 900. Guy ends up having an acute MI. Pressures are probably still super high, right? If your pressures are in the 50 at 1,000, they're probably almost 50 at 900. Why'd you choose 900? That's the question. That's if I could talk to this therapist, not the student, but if I could talk to the therapist who said, let's put them on 900, I would say, why? And then you say, I guarantee what the answer would be is, well, they're pulling 1,000, and I don't want to put them on 1,000, so I'm just going to go 900. But you have to understand, you don't really know that they want 1,000. You don't know what they want because all you know is they want more than 500. But when you give the second 500, they get a total of 1,000, but maybe the patient only wanted 550. And you would have only had to increase the tidal volume to 550 to satisfy their inspiratory demand that's coming from their central drive to breathe. You don't need 900. Well, they're pulling 900. You got to know your modes. In AC, the reason they're pulling 1,000, it's not really pulling, it's the reason they're getting 1,000 is because there's two breaths happening, one on top of the other. It's only 1,000 because 500 is set. Let's say you had a tidal volume of 400 set. If the patient was breath stacking, this would have been 800. It wouldn't have been 1,000. If it was 350 and they were breath stacking, it would have been 700. That's the way AC works when breath stacking is happening. Okay? So they increase the tidal volume to 900. Not, in my opinion, a good idea. I don't know too many people who would suggest and say, well, that sounds like a good plan. All right? So Because now you're probably delivering too much. So we always get hung up on this, and we always say, just put them on 500. But remember, you can go up to 8 mLs per kilo. Above 8 mLs per kilo is where data starts suggesting that barotrauma and ventilator-induced lung injuries and things like that begin to happen. So don't get stuck on this cookie cutter idea that, oh, everybody goes on 450, everybody goes on 500. It's a male, he goes on 500. It's a female, she goes on 400. Now, I'm different than any other male that's sitting right here next to me in terms of size and in terms of ventilatory drive to breathe, depending on the acute situation. If you had a metabolic acidosis present, the patient may have been Kussmaul's breathing, and their tidal volumes are going to be higher. Why? They're trying to compensate for that metabolic acidosis. So the smart thing to do here is to find out what your patient wants. How do you do that? You put them in pressure support ventilation. So change to PSV. Give them a pressure support of 10. Okay, maybe 12. It doesn't matter. Just give them a moderate amount of pressure support. Watch the patient breathe here for a little bit. Let them settle down from their initial angst and just watch them. Watch what their tidal volumes are spontaneously, and watch what their inspiratory flow is spontaneously. And just observe your patient and see how they're breathing. And then, if I don't have a problem leaving them here as long as it's not a strain on the hemodynamic side of things. If they look peaceful here and they're moving volume and exchanging gas and oxygenating and ventilating, then leave them here. But if your care team is insistent that you put them back in volume control, back in AC, then at least now you have data. Oh, my patient was pulling tidal volumes of 590. Okay, now I have data that I can go back and put them back in AC and change my 500 to 590. And see if that stops the breath stacking. Because now you've satisfied your patient's inspiratory demand. Their central drive to breathe is going, oh, thank you. Woo! You're no longer trying to force me to take a smaller tidal volume when I'm not going to stop asking for volume because this is what's inside of me. Okay? Put them on that. See if you can't get them in sync with the vent. And see if you don't have a better outcome in terms of oxygenation, ventilation, and overall patient care. Better prognosis for your patient. Put all this strain, 1,000 mLs with all this breath stacking, and then you switch to 900. I bet he wasn't breath stacking on 900. You know why? Because he was now satisfied. The inspiratory drive is like, oh, thank you. Oh, but I didn't want this much. And you still have these high peak pressures, and it doesn't have to be like that. He only needed 90 mLs more, maybe 65 mLs more. Maybe he did need 610, maybe up to 110. Maybe just something slightly more than 500 would have sufficed instead of having to go to 900. Okay? Now, the only other option here is to sedate your patient. Don't ever let your patient sit there and breathe, breath stack, peak pressure is 50 over and over and over and over and over again. You got to understand, you're not helping the hypotension. So you got two options. You either make the vent breathe like the patient, or you remove the patient's drive to breathe with a heavy dose of sedation. Now the problem here is that which came first? Is the hypotension due to the mechanical ventilation, or is the hypotension due to something else? And if you give a fair amount of sedation and sedatives, you might even make this hypotension worse. So, step one, always figure out how the patient's breathing. Set the vent to match that, not the other way around. Okay? Lauren, I hope this helps. I know I responded to you last night and gave you this feedback in writing, but I hope the video actually gives you a clear image of what was happening. This is breath stacking. This is breath stacking 101 to the T. Okay? Make the patient breathe like the vent, guys. Enjoy your break. Have fun. And best wishes.